Leffel and Elena Robles are both from the Vermont Department of Health, and they are our perinatal experts in the Division of Family and Child Health, and excited to talk to you today about perinatal substance use. They're joined today also by Michelle Shepard, who hopefully many of you know is a pediatrician and assistant professor at the UVM Lerner College of Medicine. And we work really closely with Michelle at the Vermont Child Health Improvement Program at UVM. And today we're also joined by Jennifer Auletta, who is a licensed mental health counselor working for the UVM Health Network at Central Vermont Medical Center in obstetrics, midwifery, and gynecology practice, and is also a fellow Blueprint participant. So welcome all. And just a really quick reminder, this is the pediatric training series. You're here today for perinatal substance use. We'll reconvene in the new year to talk about perinatal mental health. And the materials and the recordings for all the trainings will be on the Blueprint for Health website, hopefully soon. And with that, I think, Katie, I'm passing it on to you.
Hello, yes, I'm Katie Leffel, and I'm going to run over the agenda with you guys today. So we're going to talk about Vermont data from a few different sources. We're talking about the screening for perinatal substance use, including some best practices, challenges in workflow, and documentation pieces. We're going to talk about stigma and bias and how to effectively work with families with substance use. And then we're also going to talk about the plan of safe care, soon to be named the family care plan, and some mandatory reporting expectations. And then at the very end, we're going to talk about referrals and resources for children and families with where perinatal substance use is present. And the really important point here is that last one. We really want to hear from you about what the successes and barriers you have experienced with families in local communities. We're really hoping this can be sort of bi-directional. So we're presenting information, but we really want to hear from you guys. And we have couple of spaces for you guys to reflect on and answer some questions, but we also encourage you to raise your hand, put stuff in the chat, and be really interactive because we would love to hear from you. Okay, next slide. And I believe the next slide is Elena.
Hi, yes. The Maternal Mortality Review Panel conducts comprehensive multidisciplinary reviews of maternal deaths in Vermont for the purpose of identifying factors associated with the deaths and making recommendations for systems changes to improve healthcare services for perinatal people. As the years have passed, there have been an evolution of the cases and the areas of recommendations that we now work on, as more and more of our decedents have mental health and substance use factors playing as primary roles. And as we continue to understand the roles of social determinants of health. So as you can see on the screen, since 2012, 43% of perinatal deaths in Vermont were a result of accidental overdoses, but all of the 8 cases reviewed since 2021 have been a result or have been related to opioid misuse. I'm so sorry. Next slide. So presented in front of you is again our MMRP data, but we're comparing it to the national timing of maternal deaths with Vermont's timings. So for nationally, maternal deaths are happening either during pregnancy, the day of delivery, or within 42 days, while for Vermont, the majority of the deaths are happening post that 6-week period, right, between 43 days and the rest of that first postpartum year. And so we can assume that our perinatal population isn't getting everything they need from their OBs. And so this is why it's important for us to be connecting with community supports and referrals. Thank you. Next slide.
And I think to sort of recap what Elena was saying too around the timing of the death is that we've really identified not only substance use and mental health as priority areas of focus from that maternal mortality data, but we also have recognized that that postpartum period after they exit their OB care is really a very high risk time for our families. So, while our OBs do a ton of great work in that clinical space, we really recognize the need. Let's connect people prenatally so they get that postpartum support after they're out of that OB care. So, just really emphasizing that. And this is from our PRAMS data, which is a surveillance system that we that is a national data collection system on postpartum people. And Vermont, as we know, has among the highest rates of substance use in both pregnancy and in caregivers in the nation, including a range of substances, tobacco, alcohol, marijuana. And then on the right, you'll see some of our PRAMS data here from Vermont. And this is collected, self-report collected. This is data collected by self-report from the postpartum people. And so a couple of points we picked out of interest here is that cannabis use during pregnancy varies by some demographics here, age, insurance, and education. So you'll see that it trends towards younger people using cannabis in pregnancy, public insurance or the Medicaid insurance, and under high school education reporting higher levels. And then on the right, you'll see some of the substances reported. And I think it's really important here to note, although we focus heavily on illicit substances and opioid use because it's the most deadly substance in some ways for this time period in particular, but alcohol, cannabis, and cigarettes remain the most used substances during pregnancy in Vermont. Next slide, please. And then this is interesting to me on the left side, this drinking during pregnancy, and we're talking about alcohol when we say drinking, of course. And it is almost a mirror or an inverse image of the cannabis use you'll see there. So it's higher rates reported in the older populations, private insurance populations, and those with above a high school education. So it's interesting to think about when we think about substance use and we think about the populations we're discussing use with, that it's everyone we should be discussing use with, because it might be different substances and it might be different demographics. And then on the right is a little bit of information around pregnant people who receive advice to quit smoking versus those who quit while pregnant. I think that just to note here that that gray line of those who are receiving advice to quit is not as high as we'd like to see it. So we'd love to see that 68% a little higher. Of course, it's a self-report of people remembering their experiences during pregnancy. All right, next slide.
So we wanted to give people an opportunity to, and that's a lot of information. It's a lot of numbers. It's also upsetting information, even for people who live, obviously seeing the audience that we have here today, people are living with these struggles and the suffering of people, just like all those numbers were representing. So just want to reflect on that intensity of just seeing those numbers, and also to highlight what Elena was touching on in the first couple of slides is the importance of recognizing co-occurring disorders between mental health and substance use, and that I don't have like more recent data. Maybe Michelle might have this better than I, but certainly we know that people with trauma, PTSD, chronic trauma, any of that sort of family of diagnoses, they are 30 to 60 times more likely to also have substance use issues or qualify for substance use disorders. So I think for me, when I'm thinking about approaching someone in treatment, and we'll get to stigma and bias also later in the slides, but the idea of holding both of those at the same time can be tricky for many of us who are trained in either one, mental health, or one, substance use, or medically. Also for people, usually substance use is something that a specialist then would address with people. And so this presentation for me is really about the idea that we all can become specialists in our own way in this, and the criticalness of tying those, together for perinatal populations. So thinking about this also slide being an opening for people to share any reflections about the previous slides and thinking about these trends that you're seeing now with the people that you're serving. So if you have the courage to, I don't know, can people unmute themselves, or Kara, do you need to unmute them?
People can unmute themselves.
Excellent. So we're open to any reflections on the data or just what it's like to kind of be awash in this data this morning. And Elisa's also saying that people can add to the chat too if you don't feel comfortable unmuting. People might also have their mouths full of their lunch, so it might be harder to also give a reflection. But please know you can add to the chat at any point.
Hi, this is Gina O'Mara. So I'm with Northeastern Vermont Regional Hospital, Corner Medical Practice, and I'm here just for education. I have not been a part of the prenatal substance abuse and trauma. I'm just here for the education. Just because we are a practice that is open to everyone.
I think that's a great, I'm so glad that you're here. And because again, I think that in this day and age with such seemingly extreme stressors for families, to understand the connections between all those social determinants of health and how people might be managing them through substances or through other behaviors that are risky or concerning. I think, again, it behooves all of us to be looking at those and how we are feeling in ourselves about them, again, getting to stigma and bias later in the presentation, but then also having resources and ways of asking questions or ways of listening or ways of then following up with people. So glad that you're here for that education. There is a question I'm seeing from October. October, do you feel comfortable unmuting to ask your question? If you don't, I can read it.
Yeah, sorry, there was a loud thing going on, but now it's not anymore. I was wondering if there was data on which towns or counties in Vermont were most impacted, and also if it was tracked, if there was a percentage or what percentage of people who reported using substances during pregnancy, if they were in treatment programs before their pregnancy or like historically at all. I'm just curious if that was tracked as well.
Yeah, so I can jump in on that question with the data. The maternal mortality data and the PRAMS data are not broken down by region, particularly with the maternal mortality data. It's just we have pretty small numbers in Vermont, so we are very dedicated to providing de-identified data because we don't want that really sensitive data to be able to be attributed to a specific person. So so we don't break it down by towns or counties or regions. And we do have data in Vermont around overdose in the general population by towns and regions, but not by perinatal population specifically. And then in addition, was it tracked percentage of those? That I'm not, so the piece about the maternal mortality data is interesting because we don't really have access to treatment records for substance use currently, unless it's reflected in the clinical record. When I'm doing the abstraction and the review of the deaths, I can often, it will be in the medical record so I can understand, but I can't understand how necessarily stable they are. But one of the things I really think is interesting to point out here was of the cases that we reviewed in the, not this last year, but the year before that, we reviewed 6 cases of overdose deaths, and 2 were identified as being unstable, not in treatment, really a concern for everybody involved. 2 were identified as being stable in MOUD treatment, and 2 were never identified as being in treatment, never flagged as having substance use issues, whether they didn't disclose, we don't know, but all of them ended up dying of overdoses in that postpartum year. So I just think that it's really important to think of this as a universal intervention, because even if they look stable when they're in pregnancy on MOUD, does not necessarily mean that that postpartum period won't destabilize their family and their situation. So I know that doesn't answer your question directly, but that's, I just really encourage people to think of it as more universally.
Hi, everyone. It's Brina. Hi, Jen, Katie, Elena. I think the part I just want to amplify from your great frame here is, for this group, you can see why the pediatric office needs to up its game. So we have attended very carefully to the access for children in Vermont, such that these postpartum people are in your offices. We have the highest rate of well child care in the country, so they're there. And I know that we've been increasing our attention in pediatric spaces to the difficult questions and conversations that we need to be having with the parents of the new babies. And so we really want you to feel the support of this team, that it's not for the faint of heart, but you do have to lean in here. It's time to start creating spaces, much like we've done in the last few years around mental health. I feel that there's a pathway here for the way that pediatric healthcare has shown up around perinatal mood and anxiety disorder, and now the courage to then go further in wondering about substances is the frontier. So thanks for that.
Thank you, Brina. And I love that trumpeting of the courage for bringing in pediatrics and OBG and gyn care and community partners together, which segues perfectly to our next slide, which is about the web of both supports in a positive way, optimistic way, in terms of making those connections, but also the barriers that make it more challenging to connect with people who have multiple layers of stresses and traumas and barriers, which we all see. Everyone on this in this audience today knows barriers in Vermont around transportation, right? Knows the biggest fears for any parent is to be judged in their parenting or to have their child be taken away. Biggest fears, right? All of those make it really hard to build a relationship with people who we might be trying to support, that we are concerned about, that we know that there's resources that potentially could help them. And this slide for me also highlights a beautiful phrase in substance use work, which is that the opposite of addiction is not sobriety or recovery, but it is the opposite is connection and relationship. So the opposite of substance use is connection and relationship. And so the idea that we are approaching people to try to build relationship and make connection, obviously very challenging, but that underpinning feels important to keep in mind. One of the other pieces in this slide that I would just say, not every region pediatrics, be involved with OB, being involved with nurse home visiting, any other programs for housing or hub and spoke models or other treatment centers, is the idea that where is there a place in communities for those providers and staff to come together to be able to share resources, to be able to, for community response teams, to be able to share shared patients. And so again, not every community has a community response team, and there's going to be more potentially coming down, from the Department of Health around that. But just to think about where in your communities are you coming together. Any other thoughts from the panel on this big slide? An upsetting slide, because it can be overwhelming.
Yeah, I think this is a good, we talk a lot at the end about resources and teaming together too. So I think we'll be able to kind of revisit, I mean, this kind of complication of working together piece.
Okay, next slide.
So this this slide comes out of some of the the nurse home visiting work and the maternal early childhood sustained home visiting program. And so it just talks about the fact that they've learned from some of the research that we've done over the decades with the program that sometimes the conversations can be more successful if you're framing the conversation about the baby. And as you guys are, many of you from pediatric offices, so that's natural to you. But just thinking sometimes families can be more accepting of services if it's framed as being a necessary service to support the baby's development or the baby's care. And so, you know, it's a nuanced message because sometimes we don't want them to feel like the baby's the only important thing, or, you know, there's lots of nuance to that message, but we have found that families are generally a little more open to accepting services when it's framed around the importance for the baby. The other thing we like to point out too is having that conversation with them around relapse being a process and a typical part of recovery, and just sort of planning for that and having that conversation around reaching out early in the process of relapse so you can help them connect back into sobriety supports and things like that, and just making it a little more sort of expected that's a possibility. Next slide.
Can I say also that when we talked yesterday about this slide, we were also saying that along with the idea that relapse is a part of recovery, the idea that we don't want to put the pressure on someone like, if you loved your baby enough, you would stay sober. And so just balancing that with the idea that there's movement along a continuum for relapse and for sobriety, and getting supports in there is the really important part of it.
So the next thing we're going to talk about is stigma, right? Which is defined as the attitudes, beliefs, behaviors, structures that interact at different levels and contribute to both prejudicial attitudes and discriminatory practices. And so the three levels are at the structural, with policies, laws enacted by institutions, public stigma, which is those attitudes and beliefs and behaviors held by groups at the community level, and self-stigma, which is when individuals internalize all of the negative stereotypes. And one of the major facilitators of stigma is this belief that substance use is a choice. You know, it assumes a person has control over the condition and are to blame, when in reality, research shows that substance use disorder. I'm so sorry.
Hey, how are ya?
I think somebody just needs to
No
mute.
problem. No problem. I'm actually in a training right now, but an online training. Yeah, no worries.
Okay.
Even years after COVID, we either mute or unmute at wrong times.
Yeah, research shows us that substance use disorder is a condition that results out of a variety of complex factors interacting with each other. That's stress, trauma, inherited traits, adverse childhood experiences, and social environments. And so all of these things can influence an individual's thoughts and beliefs, and in turn behaviors and actions. And so you're going to be engaging with folks who might be experiencing intense shame, and as Jennifer had mentioned, that fear that they're navigating around potential loss of freedom or their parental rights. Yeah, next slide, please. And so strategies to reduce stigma when you're working with patients is approaching it through a strengths-based framework, right? So focusing on what the patient has going for them, communicating respect and hope, practicing active listening, and helping them to recognize that addiction is a lifelong chronic condition, and that recovery is a process. Next slide, please. And so in thinking about the work that you can be doing now with your teams is learning appropriate language, as in person-first language that emphasizes humanity. And you can go through this list later on because I know we're a little bit behind on the slides. And, you know, think about how you're using it, right? Language takes practice and a lot of effort. So how are you going to implement it in your documentation, or how are you communicating it with the team that you're on? It's important to respond to patients with empathy and with respect as you engage with them. Next slide, please.
So here we have another opportunity for a few minutes to check in with yourself about these questions we have framed up here. If someone feels comfortable sharing some examples of stigma that they have known for people in a perinatal setting, ways that you've seen healthcare providers contribute to reducing stigma and improving their compassionate care for this population of folks, or any other personal experiences you might feel that you would like to share today. You can unmute yourself or put in the chat. It's a funny combination of a big group, but you can also have some anonymity.
And people should feel free to reach out if you don't feel comfortable, if something occurs to you later. You can always reach out to us. And
absolutely. Well, maybe what I'll say, just to not have Elena's timekeeping get too anxious, to fill the space a little bit. Again, people interrupt me if someone feels comfortable unmuting. But when I was thinking about this slide, thinking about that there are many, many trainings available all across the state. There's rural, the CORA, I'm gonna forget what it stands for. It's about rural addiction. They have tons of free webinar trainings. There's so many trainings online to be able to educate yourselves on really harm reduction models, approaches to looking at different language, checking in with our own biases and how we can help clear that out of the way. Oh, the Center on Rural Addiction. Thank you, Elena. She just put that link in the chat there. A harm reduction model, motivational interviewing trainings, all of these types of things, having a harm reduction kit in your office to be able to offer and start a conversation with the radical acceptance of people using substances when they're pregnant or having babies. That's a sort of model in harm reduction work, the idea of radically accepting people are going to use substances. So how can you best meet them where they are? And the idea of having a harm reduction kit in your office, being able to start a conversation with, we want to keep you safe. Do you know where your supply is coming from? Do you want some test strips? Do you have Narcan, cleaning supplies, these types of things? Just really what could be a wonderful way to open up conversation with someone to say, I care. I think I'll keep us going for Elena's timekeeping's sake, but please keep put things in the chat or at a next pause and share slide. Glad to come back to this.
I think this is for Michelle Shepard.
All right. Thank you everyone for being here today. And I just wanted to kind of transition a little bit into really the whys of screening and what does that mean in pregnancy? What does that mean in all of our different settings where we touch individuals that come into our care? And right now, I just like everyone to
and think about Vermont in general. And we've talked a little bit about the rates of substance use during pregnancy, and knowing that we have elevated use in pre-pregnant people, it's not surprising that we have elevated use of different substances during pregnancy. And it's always important to talk about substance use and not necessarily just pigeonhole ourselves into substance misuse or substance abuse or substance use disorder, in that, using substances should still be discussed and people should still have information so they can make informed decisions. We certainly should be looking at harm reduction techniques as well, as there's not a black and white when it comes to using things. Again, thinking very much like how we talk to people about their use of caffeine in pregnancy. If you're doing 4 cups a day and you want to cut down to 1 cup a day, that's excellent. But certainly not, going to be penalized if you can't get to 0 cups a day. So just knowing that substance use impacts both the individual and the infant as we move forward. When we use a universal screening tool, we can identify both substance use and then what may qualify for a use disorder that really needs some intervention and support. There are many different brief screening tools that are out there, and they can certainly be on paper, they can be electronic, they can be built into the record. And really the reminder is that it is the standard of care. Next slide, please. So just to make it as big and bright as possible, the reminder is that substance use screening is not drug testing. And there is a big, does not equal drug testing. Screening is a tool, right? And there are many different involved organizations, and I like to use the ones that really come out and say, with a statement, what do we recommend? And what you'll find is that, the American Academy of Pediatrics, the American College of Obstetrics and Gynecology, the American Society of Addiction Management, they are all on the same page here. And that is really nice because it often is not that straightforward. But universal screening means that all people that can become pregnant, they're considering pregnancy, that are pregnant, and those that are coming to see me for their, before birth visits, which are my favorite, should be screened for substance use using a validated screening questionnaire. And then if there is something that is concerning on that, we can use SBIRT or screening and brief intervention techniques to counsel people and refer individuals, so the RT, the referral to treatment, for those that do meet criteria for substance use disorder and could benefit from some more intervention and treatment. Now, testing, and this comes down from all different organizations, routine testing for substance use in pregnant people is not recommended. It does not give you any more information than talking to an individual. Next slide, please. So there are many tools, and some are free and some are not free, and some are specifically for pregnancy, some are particularly for opioid use disorder. But some of the most commonly used tools are things like from the National Institute of Drug Abuse, so something called the ASSIST. The ASSIST looks at alcohol, smoking, and substance involvement screening test. And that actually looks at multiple different substances. So this one is a very broad screening tool. Many people have heard of the 4 Ps and 5 Ps, the difference being the 5 Ps has an additional layer where it asks about peers. And then it looks at both alcohol, drug, tobacco use during pregnancy. Both of them also include emotional health or depression screening and looking at relationship violence as well. Next slide, please. So one thing that I spend a lot of time harping on is that if you do a screening tool, you should know that screening tools are meant to be for screening, which means that 9 out of 10 or more times that you do a screening tool, it will be negative. And that's great. And you can reinforce that behavior and then you can move on. But if there's a positive screen, you need to do something. And it's important to have a workflow developed that works for your office in what to do with something that's positive. So, the first thing you can easily do is use another tool. Generally, an assessment tool is meant to define the nature of the problem and help you to come down some sort of pathway to a treatment option. So in that situation, it turns out that many screening tools are actually combination screening and assessment tools. So you may be able to use the same piece of paper for both. And sometimes it's not so much, and you have to do another tool. But either way, if you do nothing else in the visit, that brief intervention with motivational interviewing to really allow yourself to be curious, to be open, to be non-judgmental, and to really try to understand the pros and cons for that individual in their substance use, that's where you can start to make some headway. And that's where you can figure out what might be a nice next step. Maybe they just want to come back and talk to you a little more about it in a week. Maybe they want some information to go do some online research. Maybe they want a number to a quit line. But it's important that you really show that you're there to listen and support and not to judge and blame. You certainly, based on the goal setting set by the patient, can help them come up with a harm reduction technique, such as how can we cut back slightly? What would be the next step? Do you want to push for fully abstaining? And if so, can we set something like 3 days? Can we set small steps? Can we really make it a manageable goal? And then, of course, referring to treatment when it's indicated is absolutely an important next step for some people. Next slide, please. So as I mentioned, workflow is important. And we all know that when we have a good workflow in our, visits, in our, whether it's in the home, whether it's in the office, then we feel really comfortable. Things go more smoothly. We know we get things done. And, it just seems to really come together in a cohesive manner. So for myself, I do like paper-based. I'm old-fashioned. I like paper-based screening tools that I can look at, that I can discuss with someone. But also these, again, can be done electronically on tablets. You really want to set the stage, though, for understanding confidentiality. And again, this, in my context, comes in a lot for adolescents, but also comes into effect when, again, some of these informations, maybe they don't want them shared with their partner. Maybe they don't want that to show up in the child's medical record after the baby is born. So it is always important to talk about confidentiality and when it must be breached. I always share the results with the individual. So if you do a screening tool and you're like, hey, I noticed, and again, if this is for postpartum depression, if it's for substance use, okay, like we did this tool, this is why, this is what I'd like to do next. Can we talk a little bit about this? And I find that that's really helpful to really let people know that you're not just handing them another piece of paper. And then you need to record the information somewhere. Okay, so you should note somewhere what tool you used, what the result was, what your interpretation may have been, and any next steps that you have discussed. And I always like to add in here, please be mindful of your documentation, especially if you're using an electronic health record, as open notes, which many of us are very familiar with, means that an individual and parents or guardians have full access to what you have written in your note. Next slide, please. So here are just some examples of some validated screening tools. I know it's very small, but you can see here on the left side of the screen, just a list of different available tools that are out there. I mean, generally what I recommend is picking one tool and sticking with it so you know it well. And also that helps decrease any cost associated with it. The 5 Ps is a great screening tool. With that being said, proprietary tools often come with a cost. And so just being mindful of that as well. But you can see what this would look like, the 5 Ps in a paper-based format. There certainly are adaptations to be electronically based as well. Next slide. So I'm going to transition.
Can I say something quickly, Michelle, about that? Just to follow up that one challenge between OBGYN and midwife and pediatrics practices, at least within the UVM Health Network, is that myself as an OBGYN in that clinic, I don't have access to the child's record. So if we've done screenings with the parent, and I'm just curious about people who are in our audience too, the idea of like, getting rid of barriers of communication between like OB work and then follow up with peds, like just thinking, is there a workflow that your office or that you know of other offices have found to, if a screening had already happened in the OB office and then you're following up in the chart, is there an easy way to see that?
So I would say if it is on the problem list, we can see it to some extent. There is this magical thing that could happen that doesn't always happen, which is moving forward some of those maternal problems into the infants problem list that would make it very clear to pediatricians, like thinking in the same lane as like we kind of push really hard around if someone has perinatal hep C, we would like that to be on the mother's problem list and make it to the infant's problem list. And that helps decrease the likelihood that we're going to miss a screening that should be done. With that being said, no, I don't have access to mom's chart on the pediatric side. So anything that doesn't come through in the infant's initial birth H&P, I don't know about. So it ends up being, what I often say though, is if you have started screening in the prenatal space, it feels much less uncomfortable when I'm screening after birth. If it hasn't happened before, it can feel a little uncomfortable and invasive that I'm now asking you about your substance use during pregnancy, if someone hasn't necessarily brought that up before. And I have heard that before where, I come in and start talking about, oh, well, did you know, the products of cannabis can pass into your breast milk? Did you know that, it can affect your milk supply and things like that? And people will be like, well, I did bring that up to my OB or my midwife or my pregnancy care team, and nobody said anything. And so I do think it's important that we're all using the same messaging. I do wish it was a more seamless flow, but I also appreciate that, parents want some privacy, not in their child's medical record as well, because again, where we run into trouble is that the other parent has full access. And I see that someone's had their hand up, so I don't want to ignore you. So please, if you did want to chat, go ahead and chime in.
Hi there. Thank you. Meredith Drude. I'm the Director of Community Health Improvement and Medical Social Work Services at Rutland Regional, and aka Blueprint Program Manager. I wanted to, just sort of highlight the Pregnancy Intention Initiative, which has been going on for 10 years at this point, which involves screening for a multitude of social drivers of health, including substance use, tobacco, and mental health, along with the CSSRS screening question. The part that I'm just curious about is, in a pediatric setting, when you are screening the parent, that screening becomes a part of the child's medical record, but the child is not the patient. And so I'm curious in regards to the conversations that have occurred, because when you are providing an intervention, whether it's motivational interviewing, you're providing resources, there is a need to provide documentation related to that, but you are essentially providing an intervention to a patient who is not the identified patient. So how does that actually work? Because I think that has been an area of, I'll say it's an obstacle at this point, or a level of concern in relation to that care coordination between OB and pediatric care.
Well, I would say most of what I do in pediatrics is actually treating the parents. Every bit of anticipatory guidance I give is around the parent. With that being said, that's why documentation needs to be mindful. And part of what Bright Futures, and that's one of the things that we follow in Vermont, we do routinely screen for postpartum depression at all visits up until 6 months. And that's for whatever caregiver shows up, right? It's postpartum depression for everyone. And we recognize that parent health, mental health, substance use, all of those things are a huge part of child health, right? So at the end of the day, the other thing is that if I refer a mom for postpartum depression, or a dad for that matter, for treatment for postpartum depression, I can refer under the child. There does not have to be a mental health diagnosis for that dyad to receive treatment. And that has been a huge benefit over the last year to allow Medicaid to allow services to be provided to the dyad under the child's insurance. So I don't have to diagnose a parent or document a parent substance use disorder in order to provide those services. And most of our social workers here, the interventions that we're providing are entirely parent-based. So I think that is the beauty of pediatrics, and that this is what kind of we do. With that being said, I think there is a challenge in, again, it depends on where you document, right? There are many things about the parents that are documented in the child's family history. Some of this would fall into social history as well. So yes, of course, that will be part of the child's medical record. And again, I would hope that the child, as they become an adult, is aware of these things as they go forward, because it actually may be something that will impact their own health going forward.
I appreciate that. I think it's just a very ethically challenging issue at the same time, just in terms of trying to be thoughtful about the parents' confidentiality. I think this has come up in a number of times, even just related to pregnancy intention around screening for interpersonal violence. There's, an element of potential implications that could occur if you are providing, and again, certainly my lens is more related to the social work lens, and just trying to address some of those concerns. I do think and I appreciate your comment related to transparency around like the notion that this is something that's going to be a part of your child's chart, and agreed that certainly family systems impacts all aspects of care. I just think it does prove to be challenging, and again, I think there's an element of also just leveling up and making use of the screenings that occur within the OB practices, rather than duplicating efforts to try to combine forces and support, knowing that there is an element of screening that occurs in the OB practice as well. So thank you.
Yeah, hi everyone, it's Brina again. So many great points here, and so much of this is sort of the art of medicine that Michelle does so beautifully. But Meredith, a few points here. One, we have a significant problem in Vermont that our parents don't have primary care. And so we've had a really interesting observation in our approach called Dulce, which a lot of you know about because we've talked about it in this setting. We've added an indicator of trying to figure out how these parents who were really getting to know and asking sensitive questions of have their own medical home. So, sure. And that through line is important because, as you know, OB may see them at 6 weeks, maybe not, and then certainly doesn't see them much after that. So I think you're unroofing a very important concept about what's the frontier of pediatric healthcare in this setting, and then also how do we continue to build systems around the parents who, what we talk about all the time in Vermont is the babies are pretty darn healthy at birth. We have the lowest rate of prematurity in the country. We have incredible obstetrical care, but the families aren't doing very well. So this idea that it's being addressed in pediatrics, we can't ignore anymore. And the sensitivity around that is well understood. And I think it's a lot of the reason why people don't lean in. So there's just like a yes and going on for me. And then the last part I'll say is that your communication observation that OB has information that would be of value to peds, that's a whole body of work that I would love to pursue, because it is so silly how little we can talk electronically through that system. And we met with the Chittenden Clinic folks a few weeks ago, and it was so interesting how little information made it into pediatrics for all that had occurred in that substance use treatment setting, which is important to the care of that baby. So if anyone wants to take that on as a special project, because we have systems now, Epic, like we should be able to go whoop, whoop, push buttons and
Well, and I think it's the messaging,
yeah.
right, that we talk about in terms of care coordination, right? I think that that's the key to this, is demonstrating the value of care coordination and buy-in with our patients and families around that. I think the beauty of the Dulce model, which is also, again, supported by the Blueprint, is that it allows for someone to be embedded from, a designated parent-child center, so that there isn't that need to say, I'm going to document this in your child's record. I can really do that information and provide some safety nets to allow for some true transparent conversations. Because I think, again, thinking about a mom who may want to identify that, but has some reservations about the willingness to be fully transparent about whether it's my mental health or substance use, knowing that's going into my child's record can serve as a barrier. And I think it's important for us to be transparent about that. Give me some time, Brina. I think I still have a few more years left in me for Blueprint. So I'm always happy to take that on. We've got an incredible pediatric and PII team here. So Rutland's always willing to be a model. We'll see what we can come up with.
I just want to say really quick how much I value that opinion, especially coming in as a community health worker for the Blueprint Project. I work for Human Services, but am embedded at St. JP's, and even the startup, especially whenever it comes to documentation and clarity and how the notes are going to be taken and how the data is going to be interpreted, and all of those things are so important. And they are roadblocks, and so by even having these conversations, we're creating a bridge for the roadblocks, like where there were roadblocks. So I think these conversations are beautiful and important and valuable, and I couldn't have said it better myself. So Meredith, thank you so much for advocating and speaking to what you're passionate about, because that's what it takes. So thank you.
And I really appreciate the conversation. Most people who know me know that I'm exquisitely passionate about substance use. And I start with adolescents and work my way right through and try to, really arm people with information. And we do utilize very heavily our social work and nurse care management team here. And I think there's a really nice flow. And, I think for the most part, we get a lot of really good parent buy-in and comfort in working with our social work team, in knowing that their role is slightly different than the medical team has really been a really wonderful thing that we can add. And then they can address all of the co-occurring issues that they're struggling with. So it's also my job to work on the plan of safe care / family care plan. And for those of you not aware of how this works, the federal government has a very old law called the Child Abuse Prevention and Treatment Act. It's huge. It covers lots of different areas. But one little part of the CAPTA legislation is the Comprehensive Addiction and Recovery Act. And in this, there is a stated goal to address the needs of infants affected by substance abuse, withdrawal, or fetal alcohol spectrum disorder. With that being said, each state chooses to interpret that statement very differently, and you will find a very large variety of interpretations of that. There are very well-defined requirements, and we will go through those really quickly. But the thing being the most important here is knowing that each state is doing this differently, and that we had the purview in Vermont to interpret this in a way that we felt would still be supportive. So the requirements are to identify infants, to notify Child Protective Services, notify, not report, notify, develop a family care plan, and then annual data reporting in an aggregate manner, so not patient level information. Next slide. So the goals in Vermont were to continue to support our pregnant individuals and families that are engaged in seeking treatment for substance use or are needing to obtain treatment for substance use disorders and avoid any legislation. So we do not have legislation in the state of Vermont regarding this, okay? And so even New Hampshire, New York, they have state laws they must follow. We do not have that in Vermont. So we are hoping to support existing relationships as well as facilitate referrals to community resources, which is all of you and us. And this includes nurse home visiting as well as our other community supports. And we want to encourage communication to the infant's primary care provider. So here's where this is one method of maybe bridging that gap that we have between prenatal and post-birth providers. Next slide. So what is the Vermont Plan of Safe Care right now? It is a one-page front and back document. It's meant to be created with the pregnant person and their other involved supports. It needs to be completed by the time of birth, hospital discharge, and ideally is started and largely completed prenatally. It's a list of current supports, strengths, and areas of needed supports and referrals. It's meant to be given to the parent and caregivers as well as sent to the infant's primary care provider at the time of infant hospital discharge, very similar to the discharge summary, other things that as pediatricians need to know to follow up on. And again, I want to really bring attention to the fact that this is not something that is sent to the Department of Children and Families. This is a document for the family and to help facilitate referrals. Next slide. So to identify newborns, this comes back to our conversations and prenatal screening, so reported substance use or known prescription of medications during pregnancy that are being provided by healthcare providers. And that can be medications for opioid use disorder, that can be opioids for chronic pain, that can be benzodiazepines for anxiety. The reason those three are all called out is that those are specific medication classes that can lead to signs and symptoms of discontinuation or withdrawal in infants. Neonatal abstinence syndrome is the old term. That also encompasses benzodiazepines and barbiturates. Neonatal opioid withdrawal syndrome is the much more specific term that is associated with opioid or medications for opioid use disorder treatment. So you can either identify via screening or you can identify after the infant is born based on a clinical sign and symptoms. And in the case of fetal alcohol spectrum or syndrome disorder, you will see a constellation of physical findings or symptoms such as developmental delays after birth that would point you towards that diagnosis. Next slide, please. So the second requirement in CARA is the notification. So in Vermont, our pathway has very specific bifurcation. So there is the DCF report side of the bifurcation, and there is the de-identified CAPTA notification side. So all of us know about the identified calls to DCF. Those are very specifically in this setting, the use of substances during the third trimester of pregnancy or the last trimester for preterm birth. The use of non-prescribed or misuse of prescribed medications or suspected fetal alcohol spectrum disorder after birth. Those all fall under the DCF report side. CAPTA notifications are a de-identified form, which encompasses really the appropriate use of prescribed medications, and people should not be punished for appropriately using their prescribed medications. We do not do that in Vermont. That is not the case in other states. This also includes the use of cannabis in any format, whether that's prescribed or recreational, and that's at again, the third trimester of pregnancy. Next slide, please. So that requirement number 3 is the development of a plan of safe care or family care plan. In Vermont, we have, again, the goal that this is completed with others and again, not shared. unless if the Department of Children and Families is involved, they actually use their own safety planning document. They do not use this plan of safe care form. Next slide, please. So who completes it is different, and it depends on where you are working. So generally, again, as it has to be finished by the birth hospital discharge, the birth hospital staff is doing the final plan of safe care, and that could be a social worker, care manager, bedside nurses, other identified people. And again, at this point, that's where we're doing a notification and a plan of safe care for the prescribed use of medications or cannabis. Again, there is another provision here that there are no child safety concerns. If there are child safety concerns, whether that relates to substance use or not, that is a DCF report. That is their job. They will then decide whether or not a case needs to be opened and accepted. But we really need to, our job is to make sure that we're supporting families with substance use or substance use disorder, whichever it may be, as they move forward out of the hospital. Next slide, please. So just so everyone is aware, the Plan of Safe Care in Vermont, we were early adopters. Our first Plan of Safe Care rolled out in 2017. An updated Plan of Safe Care rolled out in 2021. And there is a new set of revisions coming out in 2025 after a 2-year process of in-depth technical assistance in collaboration with the National Center of Substance Abuse and Child Welfare. So you will see the formal change to the name Family Care Plan, which was in the 2023 CAPTA law readoption. There will be a strong push towards prenatal completion, at least getting most of the information in the family care plan so that at the time that they present to the hospital, the family is all ready to go. It's not another stressor as they're walking out the door. We're also working on an online process, so stay tuned, and an electronic method for CAPTA notifications. For anyone that has done them, they're currently being sent via secure fax. We're also working on developing a new family-centered website and support materials, and hopefully I'll have these ready to show everybody in May of 2025.
Can I also just say, Michelle, in my experience of doing these plans or offering them anyway to do with families during their pregnancy, it's an amazing tool to open up conversation, challenging in a lot of ways, of course, for fears coming up for people, but wonderful opportunity for that idea of like prevention and intervention coming together. Great to open up conversations around harm reduction, great to open up conversations around safety of the baby. All the things that we've like already touched on is ways to build relationship with the family and get them connected, you know, during pregnancy, but then beyond.
Yep, I 100% agree. These can be challenging discussions, but I promise you it's twice as challenging when I walk in at the time of hospital birth to say, oh, have you started your plan of safe care for your cannabis use? And the family's like, what are you talking about? Like, nobody mentioned this to me at all. I really believe that starting the conversation early is absolutely critical, but I also fully know that we had a long way to go with our plan of safe care materials being family centered. And so knowing that that's a goal moving forward and being able to just access a website with information, I think will be a huge improvement so that we can really help families feel less stigmatized and less targeted for being honest, because we like people to be honest. Next slide, please. So data reporting is the final requirement. And I just wanted people to be aware that, again, this is completely aggregate, de-identified information that doesn't even come with any infant family, anything at all. For hospitals that have done this before, they know that they have a 4-digit code so that we know which hospital it came from. But what this really does is allow us to satisfy what we need to for the federal legislation. And the reason we need to do this is that CAPTA is such a big law that funding is really important for other areas of child abuse and prevention. We can't lose that. we need to continue to receive that funding. And so this is one thing we have to do. And again, I just want to make sure that people know that this is literally the data they get. I'm actually showing you the table that I put in the CAPTA report. So this is showing you in 2023, we received 153 CAPTA notifications in the state of Vermont for infants that were born to parents who are using prescribed medications for opioid use disorder or using cannabis. We do know that this is going down, but also that it is likely a large underrepresentation of particularly cannabis use. Next slide, please. And I just want to show people also the indications that we had. So again, a large proportion of the CAPTA notifications that we receive is related to MOUD or MAT. And then the rest is generally for cannabis use. Next slide. And this is the current Plan of Safe Care website. I will say it does live on the Department of Children's and Families website. It's not the most fancy. And we are highly working on all the frequently asked questions and handouts. But I do want people to be aware that this is here. There's also a flow sheet that helps people follow the process of whether maybe a prenatal or post-birth report is indicated and when it's not indicated. And sometimes being able to pull that up and say, hey, you know, like, look at this. This is not a DCF report. DCF is not getting involved. This is us like making sure that we're here to support you and get you what you need and help you to feel comfortable and confident in your parenting and safety. But this is not meant to be a punishment or a, you know, immediate knee-jerk call to DCF. Next slide, please. So I'm going to just quickly say again, please, please, please check your bias at the door. And so when it comes to mandated reporting, we're all aware of how uncomfortable this feels. There are two things that you should know. And one of them is really biases are everywhere. We all have them. Make sure that you're checking it. Make sure that you provide education and support to the family, and also look for areas that we could help with that. Is there other referrals we can offer? And are we, you know, coming around this family in a way that's supportive? The other thing is, what do we know about the situation? Are we making a report based on a single statement? Are we making a report without really looking at the context? That's really important. And then the last thing, and this is something that I've been teaching for a while, it is always the right thing to do to let someone know. It may feel very, very uncomfortable, but if you need to make a report, I am a firm believer in letting the family know, and even sometimes involving them in that call so that it is not a mystery what is happening. And really, we need to think about, like, is there a safety concern, right? At the end of the day, is it a safety concern? And there can be reasons that there are substance use that leads to safety concerns, and there may be substance use and there's no safety concerns. So really, that's important to check your bias before you make the call. And then, you know, again, understanding that even if you do make the call, that does not necessarily mean that there will be a open investigation and an accepted report. Next slide. And I think we're skipping.
Yeah, we're going to skip it just in the interest of time. Sorry, guys.
Okay, well, this is one of mine, and this is one of my favorites. So my goal for the Plan of Safe Care Family Care Plan is to take these silos that come from hopefully the mom's providers, the PCP, her MOUD provider, the pregnancy providers, the post-birth providers, and all of our community support people, and take these silos apart. Next slide.
Okay, so this is just, oh, can you go back one. Yeah. This is just talking a little bit about the idea that there's the prenatal and the pediatric space, and there's a big gap that often happens for that birthing person or the caregivers around that postpartum period, and supporting the use of community supports to bridge that chasm that can sometimes develop, and really developing those community supports in that prenatal period, really pushing for, really aiming for. And so, next slide, please. This is just a quick slide. This is based on some research done around the nurse home visiting program. I know you can't see that section on the right, but what I want to point out is that the blue bars are the providers' perceptions of barriers. And if you notice, all along those lines are the provider perception of the barriers to accepting home visiting being a lot higher than folks who have engaged in home visiting, and even folks who decline home visiting. So they did interviews with people who engaged in home visiting, people who declined home visiting, and the providers. And in all of the different reasons asked why they think people declined referrals, the providers perceived a lot more that those situations are much more important than the actual people accepting the services. I'm not sure if that's making a lot of sense to you, just to understand that there is a piece of it that is provider bias around assuming that clients aren't going to accept a service that the clients themselves don't report. So that's the interesting piece of research there, to encourage people to ask people about referrals, because they may accept them even if you don't think they're going to. Next slide, please. This is a quote around breastfeeding, and I put it in here to think less about your own knowledge about breastfeeding, and just to remember, like, there are lots of lactation support experts out there in the community. You have your nurse home visitors trained, you have private lactation consultants. Some of the offices have lactation supports as well. So if you have a client asking questions about substance use and breastfeeding and you aren't sure of the answer, refer them to an expert here, because breastfeeding is very protective, or can be, lactation can be very protective factor for parents and for developing that infant attachment. So if you can encourage and support their desire to breastfeed, the best way to do that is to refer them to a professional to help protect that relationship. Next slide. This is a slide talking about the Family and Child Health Division supports. So we support a number of different interventions for perinatal people and families. And so we got nurse home visiting, we have family support home visiting, we have doula supports that we're standing up across the state, WIC, and then also the Dulce site. So we do a lot of support around these different spaces to try to connect and integrate our programs. Next slide. To really just emphasize again that connection to supports for families, we have multiple programs. We have support delivered for perinatal mental health disorders. We have one more conversation around how to have those conversations about substances, and some handouts for families around substance use in pregnancy and postpartum. And then we also have the Strong Families Vermont home visiting programs, both the nurse and the family support programs. And just really emphasizing, in particular, the Strong Families Vermont program is visiting people in their homes and bringing supports to them over that full postpartum year, prenatally postpartum year, and up to age 5. So that's a really long-term intervention for people that need that extra support. And next slide, please. So this is just talking about how every door works, in the sense of every referral door that you make, the community is well connected with each other. So using Help Me Grow is one way to do that. And they can refer out to places like home health agencies, parent-child centers, children's integrated services, WIC, things like that. If you don't want to use Help Me Grow, you have other connections at work, great. All of those connections, whether you reach directly out to CIS or you reach out directly out to the community partner you usually work with, or you reach out to Help Me Grow, just know that when you reach out. If you reach out to the wrong person, they're going to know who to refer you to. So if you reach out to the wrong person initially, that person will help you connect with someone else. So don't let confusion about the system be the barrier to referral, because we all know that the community system can be complicated at times, for sure. So we have some supports here with Help Me Grow to help you connect. But just to know that reaching out and asking questions and making the effort to refer is really important for families. Next slide, please. Recovery Partners of Vermont, there's Turning Point Center in every region, and they have peer recovery coaches, some of which are have parenting specific programs. Highly encourage you, if you have a family disclosing use and looking for resources, they are an excellent source of supports. And like I said, the peer recovery coaching is really based in, it really has a long, strong body of evidence to show that it's effective and supportive, and they're in every region. So really great support that way. Next part, this is Vermont Help Link. So this is another way to get families help for substance use. It's a, they have an online site you can call as well, and there's somebody there to answer the phone and to help connect them to substance use specific supports. Again, if you call Help Me Grow, they can connect them with Help Me Link. You can connect them directly with Help Link themselves. And they also have an interactive website with a map of resources as well. So it can be really helpful to look at with families as well. Next slide, please. I just wanted to throw a couple of slides up here for the Perinatal Quality Collaborative. The Department of Health collaborates really closely with them. And they have a lot of projects around perinatal substance use, and including in this coming year, a set of projects around clinical care and community service integration for perinatal people and newborns. So like really trying to connect those clinical and community spaces a little more effectively. Next slide, please. This is just showing the sort of map, the continuum of this community clinical linkage. I think a lot of us live in the networking coordinating space, knowing about other programs, but not really like working as effectively and collaborating as effectively as we can. So we're really trying to move that arrow over towards a collaborating, merging part where we're really linking our programs and providing a seamless continuum of supports from that clinical to community space. So really focusing on not just awareness that there's things out there, but actually collaborating and working together in a much more seamless way. Next slide, please. This is the ICON website. I put this in the chat as well. And this is a long-standing project, predates the Perinatal Quality Collaborative by a good shot, and it has a lot of resources on there and a lot of trainings, and this is a great place to reach out to if you have questions. There's providers that can help answer questions as well. Next slide, please. This is another project that Perinatal Quality Collaborative and the Department of Health are collaborating with our Alliance for Innovation on Maternal Health team. Michelle Shepard's also a part of this as well as one of the ICON members, but this is a project for perinatal substance use that we are rolling out across the state. It's in the planning stages now. You're going to start hearing about it. It's going to be coming in the year 2025, and it's a set of patient safety bundles for perinatal people, but it involves a lot of community partners, and it looks at things like updating the plan of safe care. It looks like supporting charm teams. It looks like screening and referral to treatment. It's lots of different pieces there that are supporting perinatal people with substance use and in the clinical and community systems. Next slide, please. Oh, this is just showing the AIMS bundles, and you can look at that another time on your own and the timeline there. There we go. We are done.
Awesome. Thank you so much, Katie and Elena and Jennifer and Michelle. This was great. You packed in so much in just under 90 minutes. So we're going to open up for a Q&A session, but while that's happening, I encourage you to take the